Welcome back, students, to Part 48 of our IPDRG Masterclass. Before we jump in, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. All right, today we're bringing you a masterclass explainer on two absolutely crucial major diagnostic categories, MDC 10 and MDC 11. Let's get right to it.
Here's our agenda for today. We'll do a quick recap of Part 47, and then we are going to master MDC 10, which covers endocrine and metabolic systems. After that, we'll tackle MDC 11 on the kidney and urinary tract, hit those CDI specificity rules, and wrap up with a quick summary and a teaser for next time.
All right, kicking things off with Section 1, MDC 10, covering endocrine, nutritional, and metabolic systems.
So this category is huge. It encompasses some really complex systemic issues that heavily impact inpatient hospital reimbursement, not to mention length of stay. Getting this right is absolutely essential, guys. The core conditions under MDC 10 carry immense clinical and financial weight. We're talking about things like diabetes mellitus with acute complications, diabetic ketoacidosis, or DKA, and hyperosmolar hyperglycemic state, or HHS. We also see major fluid and electrolyte imbalances here, like hyponatremia and hyperkalemia. Other massive drivers, severe protein-calorie malnutrition, thyroid crises, and obesity. Seriously, conditions like DKA or severe hyponatremia often justify a patient's entire inpatient admission all on their own.
Now, you really have to understand the financial and severity impact of how malnutrition is documented. It is a game changer. Severe protein-calorie malnutrition acts as a major complication or comorbidity, an MCC. That pushes the DRG to the highest severity and reimbursement tier. But on the flip side, moderate or mild malnutrition, that only counts as a CC, a standard complication or comorbidity. Think about that. The precision of literally one word, severe versus mild, completely changes the DRG outcome.
So, what should you look out for? Well, when a patient is admitted with just, say, generalized weakness, coders and CDI specialists absolutely must investigate further. The key indicators for malnutrition include severe weight loss, brittle nails, a lack of appetite, and pale skin. If a patient comes in with weakness and you spot these indicators in the medical record, it should immediately prompt you to check for malnutrition severity, or just go ahead and issue a query to the physician. Okay, let's look at how MDC 10 is actually partitioned. Just like most MDCs, it splits into surgical and medical partitions. The surgical side often includes bariatric procedures, think sleeve gastrectomy or gastric bypass. In contrast, the medical partition involves purely medical admissions for metabolic issues, so treating a severe electrolyte imbalance or managing uncontrolled diabetes would fall here. Basically, whether the patient hits the OR for a major procedure dictates which side of the partition their DRG is going to land on. Moving right along to Section 2, MDC 11, which covers diseases and disorders of the kidney and urinary tract.
Now, this is a massive area for coders. Why? Because renal and urinary conditions are a super frequent source of clinical documentation queries, and they cause major DRG shifts. Differentiating acute kidney injury, or AKI, from chronic kidney disease is vital here. AKI, which is coded in the N17 category, is a rapid loss of renal function that happens over just hours or days. CKD, in the N18 category, is a gradual, long-term decline. And here's the kicker. If a patient has acute deterioration on top of existing CKD, which we call acute on chronic, you must code the AKI first, followed by the specific CKD stage.
Walking through the primary diagnoses in MDC 11, we see AKI, of course, plus chronic kidney disease across all its stages, including end-stage renal disease. We also have urinary tract infections, pyelonephritis, and nephrolithasis, which are commonly known as kidney stones. Now, the sequencing of these conditions often dictates the final MS-DRG assignment. For example, if a patient is admitted for sepsis due to a UTI, the sepsis is the principal diagnosis, and the UTI is sequenced secondary. Sequencing is literally everything here. Let's take a quick look at the exact eGFR ranges for CKD staging. Stage 1 requires an eGFR of 90 or above, and it moves down progressively to Stage 5, which is an eGFR of less than 15. Finally, we have ESRD for patients on regular dialysis. Listen, specific stage documentation is non-negotiable for accurate coding. If you just have generic chronic kidney disease documentation without a stage, you are leaving clinical specificity and potentially severity mapping completely on the table.
So, let's talk about the clinical indicators for acute renal failure. According to our specific guidelines, if a patient is admitted with renal insufficiency or severe dehydration, you absolutely must check for renal failure. Look closely at the lab results and the physical exam for indicators like decreased levels of creatinine, increased levels of BUN, increased potassium, the presence of any edema, and proteinemia. Spotting any of these should instantly prompt a closer look or a provider query.
Much like MDC-10, MDC-11 has a distinct partition. Surgical DRGs here include major operating room procedures. We're talking kidney transplantation, a radical or partial nephrectomy, transurethral resection of the prostate, or TURP for urinary obstruction, and vascular access creation, like an AV fistula. Contrast this with medical DRGs, which include admissions for severe UTIs or renal failure tiering, where patients are closely monitored for electrolyte and renal clearance.
All right, Section 3, CDI and Clinical Documentation Specificity. So, how exactly does Clinical Documentation Integrity, or CDI, ensure we capture the right codes for these MDCs to avoid revenue loss? Well, the core goal of CDI is to make the medical record completely query-proof. We do this by ensuring the documentation accurately reflects the patient's true severity of illness. Common CDI query triggers help us do exactly this. For instance, with renal failure, a query is triggered to specify if it is acute, chronic, or acute on chronic. For malnutrition, the trigger is clarifying the degree, mild, moderate, or severe, often by using nutrition consults. These triggers demonstrate exactly what warrants provider clarification to ensure the highest level of coding accuracy. The crucial point here is the stark contrast between vague and specific documentation. Vague documentation simply says, acute kidney injury. It doesn't give us much to work with. But specific, query-proof documentation says, acute kidney injury due to dehydration classified as Stage 2. See the difference? By adding the underlying cause and the precise severity to the AKI diagnosis, the provider gives the coder exactly what they need. It proves the complexity of the case right from the start. Now, this quote is a golden rule in inpatient coding. The sequencing of dehydration and acute kidney injury should be based on the reason for the admission. If a patient comes in with both, there is no rigid rule that says AKI must always be coded first. You must query the physician regarding the principal reason the patient was admitted if it's not clearly documented. Remember, the clinical focus on day 1 absolutely drives your principal diagnosis. Digging a little deeper into renal failure specificity, coders really need to distinguish between acute tubular necrosis, or ATN, and prerenal AKI. Now, here is a surprising fact directly from our guidelines. The term ATN is actually a misnomer. There is minimal cell necrosis, and the damage isn't even limited to the tubules. Kind of crazy, right? However, it still remains the most common cause of AKI in the renal category. We also need stage-specific CKD coding, and we must accurately document ESRD status, especially if the patient is on regular dialysis. Basically, the more granular the physician gets, the more accurate the DRG. And it's a very similar story for malnutrition precision. To capture that highly impactful MCC for severe malnutrition, we need strict physician documentation. This often involves clinical criteria like the ASPEN/AND guidelines, severity grading, and crucially, clinical validation. While a dietitian might assess the patient and provide a severity grade based on specific criteria, that assessment absolutely must be clinically validated and co-signed by the provider to be fully codable. The entire clinical picture just has to perfectly align.
All right, that brings us to Section 4, Summary and Teaser.
To wrap things up today, we've explored the crucial DRG drivers across the endocrine, nutritional, and kidney systems. We've seen how a single word, like severe for malnutrition or capturing acute on chronic for renal failure, can completely shift those reimbursement tiers. Mastering MDC 10 and 11 is really all about capturing the true clinical complexity of the patient. But our journey through the DRG system is definitely not over yet. I want you to think about this. What drives the DRGs for the male and female reproductive systems? Well, we're going to tackle exactly that in Part 49. If you're enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Keep studying hard, and I'll see you in the next Masterclass Explainer.